Dear EDIC aspirants, welcome back. Hope you must be doing fine. After a long time, I am making this video for European Diploma in Intensive Care aspirants. I understand Part 1 is round the corner. In this video, we will discuss variety of questions related to critical care which can be directly or indirectly asked in the Part 1 exam. Let's begin. Question 1. A 54-year-old man with septic shock due to perforated diverticulitis is receiving norepinephrine and mechanical ventilation. Laboratory values: pH 7.29, partial pressure of arterial CO2 28 mm of mercury, bicarbonate 13 millimoles per liter, serum sodium 140 millimoles per liter, chloride 102 millimoles per liter, albumin 2 gram per dl, lactate 6 millimoles per liter. Which statement is most accurate? The patient has isolated lactic acidosis. B. Correcting the anion gap for hypoalbuminemia is unnecessary because lactate explains the acidosis. C. Corrected anion gap suggests an additional unmeasured anion beyond lactate. D. Winter's formula indicates respiratory acidosis. Delta ratio suggests concurrent metabolic alkalosis. Correct answer is C. Corrected anion gap suggests an additional unmeasured anion beyond lactate. Explanation: 1. Calculate anion gap. 140 minus 102 plus 13 equals 25. Normal Ag almost equals 12. So, anion gap is elevated by 13. 2. Correct for albumin. Normal albumin 4 gram per dl. Difference of 2 gram per dl. Correction: 2.5 by 2 equals 5. So corrected anion gap will be 25 plus 5 equals 30. Thus the corrected anion gap is markedly elevated. 3. Compare lactate. Lactate 6 millimoles per liter. Increase in Ag equals 30 minus 12 is equal to 18. Lactate explains only about 6 millimoles per liter. Approximately 12 millimoles per liter, 18 minus 6, of additional unmeasured anions remain. Possible contributors: ketoacids, uremic acids, pyroglutamic acid, and toxic alcohols. Calculate delta ratio. 30 minus 12 divided by 24 minus 13 equals 18 of 11, almost equals 1.6. This compatible with isolated high anion gap metabolic acidosis. For understanding anion gap, albumin correction, Winter's formula, and delta ratio, I will share the link in description and comments where you can consult in more details. Question 2. A 65-year-old patient develops profound weakness after treatment of diabetic ketoacidosis. Laboratory results: serum potassium 2.4 millimoles per liter, serum magnesium 0.6 millimoles per liter, phosphate 0.4 millimoles per liter. ECG shows QT prolongation. Despite aggressive potassium replacement, serum potassium remains unchanged. The most appropriate next intervention is: increase potassium infusion rate. B. Replace potassium both orally and intravenously. C. Replace magnesium first. D. Give sodium bicarbonate. E. Replace phosphate only. Correct answer is C. Replace magnesium first. Explanation: magnesium deficiency increases renal potassium wasting, prevents intracellular potassium retention and impairs sodium-potassium ATPase. Hypokalemia becomes refractory until magnesium is corrected. Phosphate replacement is also required, but magnesium correction is the priority. Question 3. A ventilated patient develops septic shock. Blood cultures later grow ESBL-producing Klebsiella pneumoniae. Susceptibility. Meropenem minimum inhibitory concentration 1 mg per liter. Piperacillin-tazobactam susceptible in vitro. Cefepime susceptible. What is the best therapy? Piperacillin-tazobactam prolonged infusion. B. Cefepime bolus. C. Meropenem prolonged infusion. D. Ciprofloxacin. E. Ceftriaxone. Correct answer is C. Meropenem prolonged infusion. Explanation. The Marino trial demonstrated higher mortality with piperacillin-tazobactam compared with meropenem for bloodstream infections caused by ESBL-producing enterobacterals. Extended infusion optimizes time above minimum inhibitory concentration. PKPD target, especially in septic shock. Question 4. Which intervention has demonstrated mortality benefit in selected patients with severe ARDS? Inhaled nitric oxide. B. High-dose corticosteroids for every severe ARDS patient. C. VVCMO in selected refractory hypoxemia. D. HFOV. Surfactant therapy. Correct answer is C. Venovenous ECMO. Explanation. Venovenous extracorporeal membrane oxygenation allows for ultraprotective lung rest by taking over gas exchange outside the body. The ELIA trial showed improved outcomes in carefully selected severe ARDS patients, although crossover limited statistical significance. Combined analyses and observational data support VVCMO in refractory hypoxemia when conventional strategies fail. Question 5. A multi-center RCT reports relative risk 0.80, 95% confidence interval 0.61 to 1.05, p equals 0.09. Which statement is true? Treatment significantly reduces mortality. B. Study proves no effect. C. Results are statistically inconclusive. D. Relative risk reduction is exactly 20%. Number needed to treat can be confidently calculated. Correct answer is C. Results are statistically inconclusive. Explanation. The p-value of 0.09 is greater than the standard alpha 0.05 threshold. This indicates that the results lack conventional statistical significance. The 95 CI spans from 0.61 to 1.05. Since this interval includes 1.0, it means the risk could either decrease, beneficial, or increase, harmful, making it impossible to rule out no effect. The 95% CI crosses 1.0 and the p-value is greater than 0.05, so calculating the number needed to treat would not be confidently supported by these findings. Question 6. A patient with severe ARDS is deeply sedated. Train of 4 monitoring. 0/4 twitches. On cisatracurium infusion. 4 48 hours. Sedation monitor unavailable. Which statement is most appropriate? Neuromuscular blockade ensures unconsciousness. B. Paralysis should replace sedation. C. Adequate analgesia and hypnosis must continue despite paralysis. D. Cisatracurium causes prolonged ICU weakness more than vecuronium. TOF should remain 0/4. Correct answer is C. Adequate analgesia and hypnosis must continue despite paralysis. Explanation. When a patient is paralyzed in the ICU, they lose the ability to move or show physical signs of distress. Because neuromuscular blocking agents like cisatracurium only cause paralysis and have no sedative or analgesic properties, maintaining continuous, adequate sedation and hypnosis is mandatory. Adequate analgesia and sedation must continue throughout the entire duration of the NMBA infusion to prevent pain, anxiety, and psychological trauma. Current ICU practice includes deep sedation, adequate analgesia, and lightest effective paralysis. Target TOF usually 1 to 2 twitches. Question 7. A patient with severe ARDS has plateau pressure, 29 cm H2O, positive and expiratory pressure, 14 cm H2O, driving pressure, 15. Compliance worsening. Which variable has the strongest independent association with mortality? Peak pressure. B. Plateau pressure. C. Driving pressure. D. Transpulmonary pressure. E. Tidal volume. Correct answer is C. Driving pressure. Explanation. In the landmark pooled analysis published in the New England Journal of Medicine, driving pressure was identified as the ventilatory variable most strongly and independently associated with hospital survival. It serves as a superior surrogate for functional lung stress and strain, often outperforming tidal volume or PEEP individually. Transpulmonary pressure is the pressure required to distend the lung parenchyma itself, calculated as the difference between airway pressure and pleural pressure. While driving pressure reflects overall respiratory system stress, including the stiff chest wall, transpulmonary pressure isolates the actual mechanical stress applied directly to the alveoli. It is highly useful in severe ARDS but holds a different clinical weight regarding mortality data. While high transpulmonary pressure correlates with severe lung injury and potential barotrauma, large-scale clinical trials have not shown it to have a stronger independent association with mortality than driving pressure across unselected ARDS populations. In the landmark EPVENT 2 trial published in JAMA, titrating PEEP to target a positive and expiratory transpulmonary pressure did not significantly improve survival or ventilator-free days compared to a standard high PEEP empirical strategy. Target driving pressure less than 15 cm H2O when feasible. Question 8. A patient on venous ECMO develops persistent hypoxemia despite ECMO blood flow of 6.5 liters per minute. Which factor is most likely responsible? A. High recirculation. B. Increased FiO2. C. Low sweep gas flow. D. High PEEP. E. Reduced ECMO blood flow. Correct answer is A. High recirculation. Explanation. On VVCMO, high blood flows, such as 6.5 liters per minute, normally improve oxygenation. However, if the oxygenated blood returning to the patient is immediately pulled back into the drainage cannula instead of perfusing the systemic body, persistent hypoxemia occurs. This phenomenon is known as recirculation. Signs of high recirculation include low arterial oxygen saturation despite high preoxygenator venous saturation and close proximity of the cannulas on imaging. Increasing pump flow may worsen recirculation. Question 9. During citrate anticoagulation continuous renal replacement therapy. Laboratory results. Ionized calcium, 0.82 millimoles per liter. Total calcium, 3 millimoles per liter. Patient develops metabolic acidosis. Most likely diagnosis? Citrate accumulation. B. Citrate overload. C. Hyperchloremic acidosis. D. Filter clotting. E. Hypoalbuminemia. Correct answer is A. Citrate accumulation. Explanation. In a normal state, the total to ionized calcium ratio remains below 2.2 to 2.5. An elevated total to ionized calcium ratio, often greater than 2.5, with systemic hypocalcemia, ionized calcium less than 1.15 millimoles per liter, is the hallmark of citrate accumulation. Since total calcium measures both free and bound calcium, a high ratio indicates a large buildup of unmetabolized calcium citrate complexes, which subsequently leads to high anion gap metabolic acidosis. The primary difference between citrate accumulation and citrate overload during CRRT is how well the liver metabolizes the citrate. In citrate overload, the liver is functioning normally, but the absolute amount of citrate being infused into the circuit is too high. In citrate accumulation, the liver, or muscle tissue, cannot metabolize the citrate, usually due to hepatic failure, shock, or severe hypoperfusion. Citrate builds up in the blood and binds tightly to ionized calcium. Consequently, patients develop high anion gap metabolic acidosis, systemic hypocalcemia, and an elevated total to ionized calcium ratio greater than 2.5. With a total calcium of 3 millimoles per liter and ionized calcium of 0.82 millimoles per liter in this patient, the ratio is 3.65, which is profoundly abnormal and diagnostic of accumulation. Question 10. A septic shock patient remains hypotensive with mean arterial pressure 58 millimeters of mercury despite norepinephrine, 0.4 micrograms per kilogram per minute, cardiac index, 5.2 liters per minute per square meter, SVR markedly reduced and lactate improving. Which vasopressor has the best evidence to add? A. Dopamine. B. Epinephrine. C. Vasopressin. D. Phenylephrine. E. Dobutamine. Correct answer is C. Vasopressin. Explanation. The patient's cardiac index is already high, hyperdynamic state, and SVR is low. Adding another inotrope, like epinephrine or dobutamine, or an agent that significantly raises cardiac output further is generally not the primary goal. Phenylephrine is an option for pure SVR, but vasopressin is the stronger guideline-backed choice for refractory septic shock. The VSST and VANISH trials demonstrated that vasopressin is an appropriate second-line vasopressor in septic shock with persistent vasodilatory hypotension despite norepinephrine. While these studies did not show an overall mortality benefit, vasopressin reduced norepinephrine requirements and may decrease the incidence of atrial arrhythmias compared with escalating catecholamine doses. Current international sepsis guidelines recommend adding vasopressin, typically 0.03 units per minute, when norepinephrine doses become moderate to high. See you in next video.